Dear chairs, ladies and gentlemen, let's move back to the adults and let me show you the PREPAST trial, which is an interventional trial in acute biliary pancreatitis. These backgrounds are quite well known. This is a quite costly disease, and the most common etiology is gallstones of acute pancreatitis. There have been quite a few significant papers published last year, the revision of the Atlanta classification and 2 management guidelines from both sides of the Atlantic. In these guidelines, we can see that the indication of ERCP procedures in acute biliary pancreatitis still quite a bit confusing, or can be for at least someone quite a little bit confusing. And we can see that ERCP is indicated only in patients with biliary pancreatitis and cholangitis, and it is probably indicated in biliary pancreatitis and common bile duct obstruction, but no one else. When we go back to pathophysiology, in this room, you know the pathophysiology much better than me because I'm a clinician, but everyone looks at the bile duct, and we are talking about clearing the bile ducts, clearing the gallstones from the bile duct. But no one has ever shown anything inside the pancreas, but increasing the intraductal pressure is quite a significant change in these patients. We had a non-randomized study published 2 years ago when we examined acute biliary pancreatitis patients, and we treated them with the standard method, with biliary sphincterotomy and gallstone extraction, and with or without small caliber pancreatic stent insertion. So one group received a pancreatic stent upon the stone extraction and EST, 71 patients, and the control group, which was 70 patients, received only the standard treatment. The indication for stent insertions were severe papillary edema, difficult CBD cannulation, and pancreatic duct filling or cannulation, and needle knife papillotomy. You can see that these factors are those which are quite significant factors for post-ERCP pancreatitis. But when we looked at the results, we can see that in the PD stent group, the complications rate, the morbidity rate, was significantly lower than those in the control group. And based on these data, we hypothesize that placing a pancreatic stent into the pancreatic duct can be beneficial for every biliary patient. So probably we need a randomized trial to prove this. So we designed this randomized, prospective, controlled, multicenter interventional trial, which is the PREPAST trial, preventive pancreatic stents in the management of acute biliary pancreatitis. The aim of this trial is to show that early endoscopic intervention with the usage of preventive pancreatic stenting improves the outcome of acute biliary pancreatitis compared to the standard treatment, because we hypothesize that maintaining the outflow of the pancreatic duct at the early phase improves the outcome. Why is it important? If we can prove our hypothesis, this trial can provide enough data which can change the current management guidelines. How to join in? Peter asked me to show this. We will have a similar letter to the previous studies, but because this one is an interventional trial, centers and investigators willing to join and participate in this study will be assessed by the organizing committee in terms of experience in ERCP and pancreatic stent insertion. A few general informations. The target number of patients is 230. We would like to give one authorship after every 20 patients. The planned length of the study currently is 4 years because we have 4 participating centers. the universities in Szeged and Pécs, the National Health Center in Budapest, and the County Hospital in Kecskemét. This study, the study design was ethically approved by our ethical committee, and we have already uploaded it into the trial registry, but it is still in progress. We need some payment, so the number is still pending. The inclusion and exclusion criteria are quite simple and straightforward. We need acute biliary patients, at least 18 years or older, and we need those patients where there is a possibility of performing ERCP within 48 hours calculated from the onset of pain. Of course, a written informed consent is a must. We exclude patients who are pregnant, who have other causes of acute pancreatitis, who have late disease, who doesn't have any abdominal pain because the onset cannot be assessed. Cirrhosis patients are excluded. Those patients who have also necrosis at admission, who have an uncorrectable iron level, and who had previous endoscopic sphincterotomy. We heard it earlier that if we talk the same language, it will be a benefit. So we need to define everything in the study. So the diagnosis of acute pancreatitis is, I think it's quite straightforward because we have international guidelines. So we use the IAP-APA guideline. But for biliary origin, it is a little bit confusing. You can find several diagnostic criteria for biliary origin. We use the criteria suggested by the Dutch pancreatitis study group. It is not the best one, but it is widely accepted at the literature. We think that the acute pancreatitis is of biliary origin if one of the following three present, and it contains gallstones or sludge. In the absence of gallstones, a dilated CBD and elevated liver function tests. The main drawback is the first point. So all acute biliary pancreatitis patients will be assessed for eligibility for the study, and at the admission, at the ER, we need to start the intravenous fluid resuscitation, and we need to assess the patients for cholangitis and cholestasis because these are those where the ERCP is indicated, and then we will have a randomization and the intervention and the hospitalization and further treatment. What is acute cholangitis? We don't exactly know because we have definitions written in the Tokyo guidelines, but not for acute biliary pancreatitis patients. So we need to look at this at the diagnostic criteria, and we had to modify it a little bit. So we need both from the group A, one from B, and one from C, because if you look at the A2 point, you see that a slightly elevated white blood cell count, slightly elevated CRP can be caused by the pancreatitis itself, probably not due to the cholangitis. The evidence of cholestasis is diagnosed by imaging and laboratory markers. We need to demonstrate the presence of gallstones on the dilated CBD, and we need elevated liver function tests and elevated bilirubin levels. And then this is the protocol. When we assessed the patient for eligibility, we need to assess the patients for acute cholangitis. If the patient has cholangitis, it's quite straightforward. This patient needs an ERCP, and we randomize them into two groups, the standard treatment and the PD stent insertion group. If the cholangitis is absent, we need to assess the patient for cholestasis. And if cholestasis is absent, It can be, because we use the Dutch criteria for biliary origin. So the patient can have a pancreatitis and a gallbladder stone, an isolated gallbladder stone. But if cholestasis is absent, this patient will receive conservative treatment and will be excluded from the study. If cholestasis is present, then we need to randomize this patient into an interventional group with the standard treatment and the PD stent insertion treatment, and into a conservative treatment group, because there are publications that the cholestasis can improve within 48 hours for acute biliary pancreatitis patients. But if the cholestasis is not improved within 48 hours, this patient will receive endoscopic treatment and will be excluded from the study. The primary endpoint, we would like to use a composite endpoint, including a moderate or severe course of pancreatitis or any complications. It can be systemic or local complications, and including the mortality. And we will have a few secondary endpoints, which are related to the ABP outcome, multi-organ failure, mortality, pain score, sepsis, severe course or severe organ failure. And there are a few endpoints related to the endoscopic treatment itself. For example, the stenting succession rate, the failure, what happens with the attempted but failed pancreatic stenting patients. We can analyze the endoscopist experience on the success rates and the outcome. Also, we can analyze the influence of the endoscopic technique on the outcome of the ABP. And we can include those risk factors that are well known and described for post-ERCP pancreatitis, and probably we can analyze these data as well. Thank you for your attention.
Any questions or comments?
This is actually very exciting. Congratulations.
Thank you very much.
But we definitely need to go to the large volume centers, right? The centers which
exactly.
have a big experience in ERCP. So this
exactly.
going to be small limitation.